The hemodynamic management of the neurologic patient. I had noticed yesterday when I did my presentation, or probably an hour after I did my presentation, that there was an error. So last night I went back and corrected it, and then compulsively added a few more things to my lecture. So this will be a bit different from your handout. I've asked the ladies who have been so gracious to run everything to send a copy of the new lecture to everyone via email. And I'll point out where I made the little error, but that's what happens when you have a 9-year-old as your editor when you're doing a presentation. So anyway, so hemodynamic management of the neurologic patient. This is a very broad subject, mostly because the data sends us north and south, east, west. We should do this, we should do that, and it's just not very clear exactly how we should manage these patients. We do have a general idea of what we should do, but it's so broad, it's really just a very complex juggling act once they've had the initial insult and trying to control for all of the secondary outcomes and try to protect as much of the brain as possible. So I'll try to be concise yet broad in my discussion. Okay, so goals of this lecture would be discuss the physiology of the cerebral vascular system, and you'll pardon me if I repeat anything from earlier today. Differentiate the common presentations, and then discuss the management strategies for these patients. So the physiology of the cerebral vascular system. The neurons are dependent on the blood flow for their metabolic requirements. We don't have these massive ATP stores, glucose stores, oxygen stores like our other cells do. So the blood flow, it's absolutely dependent on blood flow. You cut the blood flow off, the brain doesn't get its basic nutrients. The cerebral blood flow is roughly, at minimum, 50 mils per minute per 100 grams of tissue. And this is supplying glucose and oxygen. And these are the basic building blocks for the production of the brain's needs. A few of the terms that I'll be using: cerebral perfusion pressure. This is the perfusion pressure across the brain and the major determinant of cerebral blood flow. And it's equal to the mean arterial pressure minus the intracranial pressure, or the ICP. What is the ICP? It's the pressure within the cranium, essentially. Normally, most of us sitting here, we're probably somewhere between 1 to 7. And in the normal brain, we accept 1 to 15 millimeters of mercury. Intracranial hypertension is defined as pressure of over 20 millimeters of mercury for a sustained period of time. So if you sneeze, your intracranial pressure might go up to 25. But it's transient, the blood flow continues, and you have no issues with it. And what we're concerned about is what's been defined by Monro and Kelly, which are two, one is British, others are Scottish physicians, who quite morbidly cut a bunch of brains apart after a major flood and said, hey, we've noticed that the brain seems to swell, and it seems to get compressed. Why is that? So they've defined that there's a finite volume within the cranium. There is some decompression down into the spinal canal, but still there is a finite amount of volume that can fit in there. And the volume is made up of your blood, CSF, and brain. And any increase in this volume will dramatically increase the pressure and therefore decrease your cerebral blood flow. So you get an increase in CSF, then your blood flow drops off. You get an increase in brain tissue like edema, swelling, or tumor, then you get a decrease in your blood flow. These all are auto-regulated, or at least CSF and blood flow are auto-regulated to keep that flow continuous, but anytime you have any type of disturbance in these three factors, then the pressure within the intracranial vault goes up, and you'll see the consequences. So I love graphs and charts, but it very nicely just shows here everything's just kind of trucking along fine. Your cerebral blood flow, intracranial pressure is fine. But once you get to this critical volume, you have an exponential rise in your intracranial pressure. And sometimes this may be just a matter of 20 to, well, probably 50 mils of fluid that tips your patient who is just alert and oriented to completely obtunded and headed for a downward spiral. So this is a very critical point, and our goal essentially post-brain injury, post any type of disturbance in the volumes in the cranium is trying to keep everything on this side so that we don't get these secondary outcomes from brain injury. So the symptoms of intracranial hypertension, they'll progress, a bit of a headache, neck stiffness, nausea, then you'll get ocular neuropathies, decreased level of consciousness, then papilledema. And then when it reaches its critical, the patient looks like they're about to cone or push brain tissue down the foramen magnum, then you start getting Cushing's triad, which is hypertension, bradycardia, and irregular respiration. And this can progress quite dramatically, particularly if you're looking at the anterior versus the posterior brain. The posterior vault essentially is much smaller, and a small injury to the posterior part of the brain can have dramatic consequences versus the supratentorial, where there's lots of space and you won't have such a dramatic change. So the protective devices or evolutionary mechanisms that we've developed, collateral blood flow, 70% anterior, 30% posterior, bridging circulation through the circle of Willis, and then autoregulation. In autoregulation, the brain is able to, the blood vessels are able to vasodilate, vasoconstrict based on what its needs are at the time, and adjust its oxygen extraction fraction and work together. But when you have injury, then that autoregulation that's been so eloquently made becomes very dysfunctional. So we'll discuss this a lot throughout throughout the day, the penumbra, which I think is one of my favorite words. It's actually a video game with a zombie. So essentially you have this dead tissue, which would be the core of the insult, and then surrounding it you have this area of variations in ischemia, perfusion, blood flow. And our goal for our management is to protect the penumbra. The dead tissue, we have to accept that that's gone. It will liquefy. It will no longer be the issue. But this penumbra is where you have most of your consequences from brain injury. So the injury. When our cerebral blood flow drops below 50 mils per minute per 100 grams of tissue, you start seeing a slow EEG. You get a little bit slower flow, 15 to 25 mils, loss of electrical activity, 10 to 15. You still have a bit of ATP made, and that's our major major energy for the brain tissue, and it's maintained. But once you get below 10, ATP is gone, and that's 2 to 3 minutes. So that's why time is brain, and we need to get moving on these patients to protect the cerebral blood flow as quickly as possible and as aggressively as we can. So the injury, lack of nutrients, oxygen, glucose, nutritional, B12 deficiencies, tumor, trauma, infection, metabolic inflammation, all leads to ischemia and infarction. And then you have impaired autoregulation. Reperfusion injury, we'll talk about this a lot. We'll have patients who present 8-10 hours out from a stroke, and we may not be able to help those patients because if we do go in and suddenly remove these emboli or strokes, we may actually get a significant reperfusion injury, and in particular to the penumbra, or this ischemic tissue that could potentially be saved, but we have just flooded it with rich blood full of white cells, which impede blood flow. You get free radical formation, cytokines, which leads to cell destruction, vasoconstriction, edema, and then damage to our very critical penumbra. So again, I just love my little chart. But what's important here is that you can see that there is a range where our cerebral blood flow can be relatively preserved at different mean arterial pressures. But once you get below those mean arterial pressures, you get the sudden and sharp drop-off. And then also looking at your intracranial pressures, again, at a relatively fair range of ICPs, or intracranial pressures, you get decent blood flow. But once again, you pass this critical point and your intracranial pressure is raising, getting higher, much more severe, and then your cerebral blood flow is essentially reduced to nothing. Okay, so how does this relate to blood pressure management? This is what really makes it difficult for us to create solid guidelines to say we must do this in every patient, or we must do that in every patient. When you have patients who are normally hypertensive and they present with ischemia, they're actually, their normal mean arterial pressure to maintain their cerebral blood flow is actually shifted. So these patients that are hypertensive may need a slightly higher mean arterial pressure to maintain the same cerebral blood flow. Whereas a patient who's normotensive, let's say this is a trauma patient that presents with a head injury, they can tolerate a bit more hypotension. They can tolerate these lower blood pressures, lower mean arterial pressures, without significant reduction in their cerebral blood flow. So we really do have to look at the patient, look at the patient's history, look at their trends, where did they actually present with regard to their blood pressure, and how are we going to control it. Okay. So the different presentations that we have. There's a very nice article, it's a radiologic article, that talks about the 4 Ps of acute stroke. And I like little simple rhymes and memory tools. So the 4 Ps, parenchyma, the pipes, perfusion, and penumbra. Ischemia versus hemorrhage, large arteries or veins involved. You can have significant thrombosis of the venous system and again present with stroke symptoms. But that's another discussion on another day. Perfusion, collaterals, and net circulation. And then penumbra, the brain tissue that is ischemic but not infarcted. The diagnostic modalities, I'm sure they were discussed. For most patients, particularly at VBMC, it's much easier to not only get a CT, but have a CT read. So most of our patients will start out with a CT brain without contrast for the initial diagnosis. Then may progress to CT angiography. Sometimes if you're at hospitals, I think we were discussing last night that someone was in Hawaii and a partner had a stroke, and suddenly the MRI was available. An MRI was easier to get into, therefore MRI was done. So on a rare occasion, MRI might be your initial diagnostic modality, but relatively rare. And then for that small percentage of patients who present either with a late subarachnoid hemorrhage, or it's just not very clear, or the CT scan just isn't giving you the pictures that you want, a lumbar puncture would be your next go-to diagnostic modality. But I'm sure that's been discussed. So parenchyma and pipes. 80% of the strokes that we'll see will be ischemic, whether it's thrombotic or embolic, arterial versus venous, but a majority of them will be arterial thrombosis. And then a smaller percentage will be hemorrhagic. Most of them will actually be as a result of trauma, but you can have hypertensive intraparenchymal hemorrhages, subarachnoid, epidural, or subdural. So the management strategies are really based upon your presenting condition and what it is. Is it arterial? Is it subarachnoid? And we'll go from there. So key concepts. It's very important. Yes, it's great to protect the brain. We want to make sure that we are moving quickly and addressing the stroke, but if you have a patient who's not breathing and we're busy running them through CTs, that's a failure on our part. So we always need to remember our airway, breathing, circulation. Airway patency, does the patient need to be intubated? This can be done very quickly while they're getting the CT ready and everything is getting managed. Breathing, oxygenation. In the past, we used to throw as much oxygen as we could on patients, try to get the PaO2s in the 300, 500 range. So we're finding that patients with hyperoxia actually have worse outcomes than normal oxia. So not too much. Just take it easy. Circulation, cardiac monitor, blood pressure, get your peripheral IVs in, do your initial labs, and we want to do this quickly. And I think it's very important, particularly in the emergency department, that we get appropriate peripheral IVs in also. We're not putting in, 26 gauges in the finger in a patient that we want to get a cerebral angiogram. We're putting in 16 to 18 gauge antecubital, 2 peripheral IVs, so that we have adequate access so that our procedures, our diagnostic procedures can be done quickly. And then basic labs. From what I understand, we're now using iStats in order to get our patients moving quickly. It can take up to an hour and a half to get creatinine in some hospitals, but now with the iStat, we should be able to get them within minutes. And then look for the level of disability. Let's do our initial NIH-SS, and check the glucose, because sometimes it's not a stroke. It could be just hypoglycemia. So before we TPA somebody, we should always know what their glucose is. So circulation, I would actually even move up to the top, even though it's easy to remember ABCs. But circulation, make sure that your circulation and you have addressed those issues first and foremost. So since we're really geared towards discussion about subarachnoid hemorrhages, I'll just kind of quickly gloss through ischemic stroke. But it presents with an ischemic core and then the penumbra, usually in 2 stages. Stage 1, autoregulatory vasodilation, but most of our patients actually present in stage 2 with a reduced cerebral blood flow, increased oxygenation ejection fraction, and quite hypertensive. And usually stage 2 lasts for 24 to 48 hours where they're just, for whatever reason, protective reason, they are hypertensive, which, again, further complicates, do we try to lower their blood pressure, do we try to keep their blood pressure where it is? It just makes it difficult for us to make those determinations. So ischemic stroke, 60–80% present with hypertension, and it's unclear if that's protective. What is clear is that the extremes of blood pressure have a higher mortality and morbidity. So your patients who are hypotensive or come in with severe hypertension, systolics in the 280s, I've seen up to 320, 350, definitely have a higher morbidity and mortality. And we do want to control those blood pressures and bring them up to a mid-range. The initial is our first goal is to decide exactly how we're going to manage these patients. Are they going to go for initial thrombolysis or a definitive procedure or endovascular intervention? And then we also want to pay attention to our medical management, aspirin versus aspirin plus clopidogrel, probably more accurate. We want to pay attention to other causes that might be making the stroke more complex. If a patient's on vitamin K antagonists like Coumadin or the factor 10A inhibitors or the very dreaded direct thrombin inhibitors, trying to reverse those anticoagulants before moving forward. someone actually asked a question yesterday about reversal or antidote for the 10A and direct thrombin inhibitors. And I actually checked online last night, and there actually are two antidotes that are coming out. One is actually supposed to hit the market next month for the the factor 10A inhibitors. And there is currently a medication in the works for the direct thrombin inhibitors. So very positive for us, as we probably have all seen to some degree significant bleeding from these medications. And they further complicate, can we actually even do thrombolysis or endovascular management in our stroke patients when they present. And then blood pressure control, which we'll discuss. So right now, we're really at the point where it's consensus guidelines for what to do with blood pressure. The American Heart Association, I think it's their 2013 consensus statement was the most recent. We're basically telling us we don't really know what to do with these patients, so let's just focus on the post-thrombolysis. And then the others be conservative, but we're not going to make any clear recommendations on that. So post-thrombolysis, blood pressure is recommended less than 185 over 110 diastolic. Oops. I don't know what I did there. What was I? So less than 185 over 110. Higher than that, patients tend to have significant increased risk of hemorrhage post-thrombolysis. And then otherwise, they recommend a general 15% reduction in the first 24 hours in patients, in all comers who present with an ischemic stroke. So there is some support for permissive hypertension in the first 24 hours, and that's tolerating systolic blood pressures up to 220, diastolic up to 110. But for me, that's very hard to do. It makes me very anxious, but by continually reevaluating the patient, doing recurrent neurologic assessments, and early CT scanning, if there is a significant change, it does give you a little bit more leeway to allow for permissive hypertension. Hypotension also has very limited data, exactly what we should do for these patients. We do know that systolics less than 130 do have worse outcomes, so the recommendation is to try to keep systolics greater than 130, and somewhere 130 to 150, even 180 is your goal. For hypotensive patients, vasopressors, unclear benefit for individual drugs. There's always the debate, oh, why did you use this drug, why didn't you use that one? But in reality, for most of the studies that have been done, it's just not clear. We do know that there are certain vasopressors, dopamine in particular, that have an increased incidence of arrhythmia, but other than that, we just don't really have clear data. So I typically don't make recommendations. Everyone has their favorites. Stick to your favorites. Or look at the individual patient's factors and determine which vasopressor with activity at whatever receptors will provide your patient with the outcome that you're looking for. Fluids, again, there is no clear recommendation. There's the Elias pilot trial that demonstrated the safety of albumin in acute ischemic stroke. And it actually did find that patients treated with albumin, with all things being equal, actually did have better outcomes than patients treated with the equivalent normal saline. But it was a relatively small and I would think statistically insignificant improvement, but it's equivalent. So albumin, lactated ringers, plasmolytes, whichever your favorite is. And I think AHA actually did make a recommendation to give patients 1 to 2 liters of fluid, isotonic fluid resuscitation if they are hypotensive, and then consider vasopressor. Embolic stroke, again, more controversy. Atrial fibrillation is usually quite common, or you can have embolic strokes in the carotid. Controversial whether or not to anticoagulate these patients. The general rule of thumb, if it's a very small area, the patient remains in atrial fibrillation, anticoagulation would be appropriate. If it's a very large area of infarct or ischemia, you do have the risk of converting an ischemic event to hemorrhagic, so avoiding anticoagulation would be appropriate. Rhythm control, again, we're not recommending cardioverting patients who are in atrial fibrillation. Really, rate control is the goal. So hemorrhagic stroke. The most common cause for hemorrhagic stroke would be trauma. Then we have hypertensive strokes, but since we are moving towards our interventional procedures or endovascular procedures, I'm going to talk more about subarachnoid hemorrhages. And this is actually where the error was in the previous handout. For some reason, I started writing AVM, but it's aneurysm. So subarachnoid hemorrhage management is really dependent upon what stage you are in the patient's management. Is it an unsecured aneurysm post-subarachnoid hemorrhage, or secured aneurysm post-subarachnoid hemorrhage? These three are completely worlds apart in the way that we manage it. So identifying where the patient is in the course is key. So subarachnoid hemorrhages, the vast majority of these, as I said, are traumatic. The non-traumatic or the spontaneous are predominantly Barry aneurysms, or predominantly aneurysms, again, predominantly Barry aneurysms. The complications from the acute subarachnoid hemorrhage would be acute hydrocephaly with increasing intracranial pressure. In these patients, you would consider putting an extra ventricular drain in, or early rebleeding. Cerebral vasospasm is the big fear that most of us have. Parenchymal hematomas, seizures, and then other medical complications. Medical complications, neurodeficits, hepatic dysfunction, respiratory failure, pneumonia, ARDS. Patients can get an acute neurogenic pulmonary edema, Takotsubo's cardiomyopathy, where they develop essentially cardiogenic shock due to just the huge adrenergic outflow. They will have elevated troponins, appear to be in shock, and when you look at their echocardiogram, they just have this big, saggy, baggy heart that's barely functional. They may have had an acute MI as a result of their large adrenergic output. Then also acute renal dysfunction, and that was supposed to be endocrine deficits, sodium abnormalities. So for subarachnoid hemorrhage, when it's an unsecured aneurysm, it's definitive management. This is up to the interventionalist or the neurosurgeon. Are they going to go for endovascular, neurosurgery, or just monitoring where they do nothing? And for those patients, you want to generally maintain a normal blood pressure. If they come in super hypertensive, you want to progressively bring their blood pressure down. But typically, these patients who are unsecured, we're not going to do anything, we won't see them in the hospital. But the unsecureds that are being prepared for a procedure, they may be admitted several days beforehand to control their blood pressure, that anesthesia and the proceduralists are satisfied that when they go in to do their procedure, it's done safely. Unsecured aneurysm post-subarachnoid hemorrhage. Again, you want definitive management, usually within 24 hours of their initial presentation. There's always a big debate, clipping, coiling, early, late. I let the proceduralists duke that out and go about with my blood pressure control. But you want to avoid the extremes of blood pressures. In these patients, yes, you do want to progressively reduce their blood pressure because the higher the pressure, the more blood will be squirting out into your cranium. But the lower the blood pressure, then you start getting ischemic changes and this damage to the penumbra. So you want to find some type of median. Usually we try to keep the blood pressure somewhere between 150 to 180. And then we're also trying to control what if there are any other factors that are contributing to this hemorrhage. If the patient is anticoagulated, you reverse the anticoagulation. If they're having seizures, then you want to control those seizures and maintain that normalcy and get the patient as stable as possible prior to their procedure. Then secured aneurysm post-subarachnoid hemorrhage. All of our efforts then go into prevention of vasospasm and management of these secondary outcomes after the aneurysm has been secured. So vasospasm. The etiology is very complex. It's not even actually clear what causes it. It's not clear why some people get it. They can have a large clot burden, and one person has it, another person has a large clot burden, and they don't have vasospasm. It seems to be very clearly that it's an impaired autoregulation. There's an imbalance between endothelial messengers, neuronal cell death, and free radical liberation. But patients can have all of these present and still have no vasospasm or severe degree of vasospasm with very little imbalance in the endothelial messengers. Linda had discussed the transcranial Dopplers. Mainly what they do is look at the velocities. Greater than 120 centimeters per second, usually those patients, especially if they are symptomatic, are rushed to back to the endovascular suite and are taken for some type of definitive procedure. But we're actually looking at even the more subtle changes. Patients, when the TCDs are done, basically each day in the chart, the ultrasound tech will come in, look at the velocities of the major blood vessels in the head, and then record them. And you'll look at what the general trends are. I think here on day 2, or day 3, you can see that the left ICA, left MCA look like they're generally stable, but your right MCA is jumping up from 42 the first day to 140. For those patients, for this patient, we would probably start saying, okay, we need to make sure that we're much more aggressive with our therapy. We make sure that the neurointerventionalist knows these velocities are changing, and we want to monitor these patients more closely. In some hospitals where you have neuro step-down units, these patients would be transferred back to the intensive care unit. Even if they're completely asymptomatic, there's nothing going on with them. It's just that they're in such dangerous territory with this spike that we do need to keep a close eye on them. So I do prefer when they leave the little graphics so that I can walk by and say, ah, spike, someone needs to call somebody. It makes it nice and easy. So vasospasm prevention. I don't think we really know exactly what to do. We know that nimodipine is well studied. We know that giving nimodipine to patients who remain relatively normotensive seem to do well, but we don't know why nimodipine works in some patients, does nothing in other patients, and other patients continue to get worse. But we don't really have anything else, so everyone gets in nimodipine on either on admission or when the aneurysm is secured. Some hospitals where I've worked in, we've tended to delay until after the aneurysm has been secured, just because you can get these broad swings in blood pressure. But most hospitals, nimodipine is started almost immediately on admission once a spontaneous subarachnoid hemorrhage has been identified. And then we initiate our dreaded Triple H therapy for prevention, And then there's other novel therapies that we've tried, but really don't seem to give us much bang for our buck and are definitely no better than nimodipine or Triple H therapy. So nimodipine clearly a benefit in the prophylaxis of vasospasm, so we give it. Triple H therapy, what is it? Why do we do it? It's essentially hypertension, hemodilution, and hypervolemia. And these theories are based on studies from the 70s to 80s where they found that when you drive the blood pressure up, the mean arterial pressure greater than 100, you hemodilute them, where you drive their hematocrit down to less than 30, which most ICU patients are less than 30. And then you give them huge amounts of IV fluid. They seem to have better outcomes in some studies. But for most of us who live through these early and middle stages of Triple H therapy, most of the patients ended up with Swan-Ganz catheters, inflorid pulmonary edema, intubated, and we just are searching in the dark and following these recommendations that really didn't have much science behind it. So now we're all just kind of finding our way in the dark and grouping together in little groups in the dark. So there are some very nice studies done that basically just asked intensivists, neurointensivists, and endovascular proceduralists, how do you manage your patients? What do you do with these subarachnoid hemorrhages? And the result was they were just all over the board. 40% of intensivists said that they follow Triple H therapy to a T, but 60 to 70% would say, I try to keep them euvolemic, I try to keep their blood pressure up, and I really just keep doing daily blood anyway, and everyone's got a little hemoglobin and hematocrit. So in my experience, what I've found is that we don't need to push patients over the edge. We don't need to push them into pulmonary edema. We don't need to go all out. I think being relatively conservative and doing repeat examinations and evaluating the patients and treating them as individuals has the best outcomes. And that's what the current recommendations are, that we don't go too overboard and just take it easy. So hypertension, really no clear benefits of one vasopressor over another. Phenylephrine is a nice alpha agonist, alpha-1 agonist, peripheral activity predominantly. It can be given through a peripheral IV, so it's just nice and easy. You don't have to do a central line and have to accept the morbidity from that. Norepinephrine can augment the cardiac output, and you may have some improvement for cerebrovascular flow. So again, you may choose that in some patients. But either way, your goal is to get your mean arterial pressure greater than 100. Hemodilution, as I said, good luck finding a patient in ICU with a hematocrit over 30. So that usually is just easily done. And then hypervolemia. Most hospitals where I've worked, we've just tried to limit to a total of at least 3 liters input throughout the day, or 3 liters positive throughout the day. And you look at the individual patient. If your patient has renal failure, they're already intubated in fluid pulmonary edema, you might go down a little bit on this requirement, or you might go up on a patient who has diabetes insipidus, they're peeing their brains out, and their sodium is 170. You just want to treat the individual patient, but your goal should be at least euvolemia in these patients. So as I was saying, we just can't agree fully on the recommendations. There's the Veli group and Meyer group, and essentially we're just all over the board with our management. But we do know that aggressive management and aggressive blood pressure management, aggressive fluid resuscitation gives us the best outcomes in these patients. So Triple H therapy, endovascular management for vasospasm treatment. angioplasty, vasodilator therapy, which again, I leave that up to the proceduralist. They just tell me what they've done, and then I go with it. Trauma, we'll just address that very briefly. Subarachnoid hemorrhages, epidural, subdural, and then intraparenchymal hemorrhages. Really, our goal is damage control resuscitation, which essentially means that we are very aggressive very early on to control the bleeding. Once you control the bleeding, all aspects of the bleeding, that will give you the best outcomes. So our goal is to maintain a normal blood pressure, avoid hypertension and hypotension, and then definitive therapy to evacuate the hematoma if it's indicated. Seizure prophylaxis for 10 days is the industry standard. And then temperature goals, depending on the day or who has purchased you dinner, your goal might be hypothermia. But the general theory is that keeping the patients fever-free or normothermic has better outcomes than hyperthermia or having a febrile patient. So even for our subarachnoids, our goal should be to keep them normothermic and avoid fevers at all costs. So damage control resuscitation, if you're not familiar with it, maintaining the pH. Patients who have severe trauma end up with severe acidosis, which adds to the coagulopathy, which increases bleeding. They get a dilutional coagulopathy because we go crazy, particularly with our fluid resuscitation, and we forget we should actually give blood. And we should give FFP and cryoprecipitate. Maintaining or avoiding hypothermia, and again, if it's a bleeding patient, you don't want to make them hypothermic. Those are the patients that you would allow to trend back up to normothermia. And then source control is the key tenet. So if your patient's bleeding, has a head full of blood, you can do all of this stuff, but if they're not headed to the OR or to an interventional procedure quickly, you're not serving your patient well. So correct your coagulopathies, get your neurosurgeon lined up, and get them to the OR quickly. So we'll discuss briefly ICP monitors. I know that at Vassar Brothers we really haven't used or maximized our use of ICP monitoring and intracranial drainage devices. But the major ICP monitors that we have on the market would be the data only versus the drainage. The data only comprise of the invasive, which are intraparenchymal, which is probably the most common data only device, intraventricular, subdural, epidural, and then the non-invasive would be the IJ catheters, looking at oxygenation, lactate formation, and other factors, which I think will be beyond the scope of our practice for at least the next year. And then our other ICP monitors would be ones that provide us not only monitoring, but also drainage, which would be our EVDs, ventriculostomy, or lumbar puncture. EVD is probably the most common. So just a nice picture of what the catheters look like. The Codman catheter is probably the most common use worldwide. It's a nice, very simple little catheter. You drill a little hole, drop in a fiber optic catheter to strain gauge. You're excited by that. That monitors the pressure at this site. Unfortunately, the brain is not just here. It's actually here, down here. So you do have to use it with some degree of caution. It may not necessarily tell you exactly what's going on in the rest of the brain, but it can give you an idea of how aggressive you need to be with your resuscitation and how aggressive you need to be with managing your intracranial pressure. The other would be the extraventricular drain, which is a very nice picture. It's a very nice, simple, eloquent, and inexpensive device. Neurosurgeon, again, would place this, could be at the bedside, but most often these are placed in the operating room, where they place a catheter with several drainage holes into the ventricles, and then it has this nice drainage device, or drainage system, where you can monitor, you can sample. If the ICPs are high, you can actually drain some of the CSF, and then again, and thus reduce your ICPs. They do have a risk of infection. There's a risk of actually introducing fluid or bacteria or whatever into the ventricle. But it's relatively rare for these to develop true infection. A lot of the times you actually just end up treating infections, even if you don't believe there's one, just because the patient's febrile or whatever. But this is probably going to be the standard device that we'll be using in our patients who need a drainage device. So moving on to antihypertensive therapy, the ideal agent for an antihypertensive would be something that's short-acting, easily titratable, metabolized independent of organ function, and has a positive effect on cerebrovascular bed. Unfortunately, this doesn't exist. So we just have to look at the individual drugs that we have, what their side effect profiles are, what receptors they affect, and then decide which medication is best for our individual patients. So ACE inhibitors are wonderful medications. Enalapril is an IV form. It's relatively short-acting. But if you have a patient with significant renal failure, everybody runs for the hills for it. And it is a bit longer acting than some of the other medications. Beta blockers, labetalol, you'll likely hear a lot about, but esmolol is another medication that you could use. But when you have a patient who has Takotsubo's cardiomyopathy or is in cardiogenic shock, beta blocker might not be your brightest idea for medication to use. Calcium channel blockers, probably the most commonly used for blood pressure medication or management would be nicardipine. It's an arteriolar vasodilator, so it acts on the arterial bed, so you can maintain your preload. It has a very short half-life and works very well. So this is probably one of the better drugs to use. Nimodipine, your patient likely is already on, but as Linda alluded to, these medications, or this medication, some patients just can't tolerate it. And you may actually find that your patient's on nimodipine and norepinephrine, where you're chasing every time you give nimodipine, the blood pressure drops, then you're cranking up your norepinephrine and trying to keep the blood pressure at your minimum, or your mean arterial pressure at 100. So despite that, we still give them nimodipine, though, and we try not to withhold it. Hydralazine is another drug, but its half-life is a little bit longer. It has some other side effects that most physicians are concerned about, so it's not perfect, but when all other drugs fail, it's one that can get your blood pressure down relatively reasonably. And then nitrates. I'm not a huge fan of nitrates because they are a general veno and arterial or vasodilator. So if you do have impaired cardiac function, you can knock out your preload, and then your patient's actually becomes profoundly hypotensive, and now you're chasing that again. So I would probably choose nicardipine above other medications. And then hypertensive therapy. Again, vasopressors, really no preferred management strategy. Phenylephrine, norepinephrine. Use dopamine if you really are married to it. And there's multiple other medications that you can use. Fluid resuscitation. We do tend to try to stick with isotonic fluids. I do think that normal saline in the next few years, particularly the next 5 years or so, is going to start getting phased out because there is significant morbidity from metabolic acidosis that large volume saline resuscitation can give you. So I think resuscitating with lactated bringers is very reasonable. Plasma-like and albumin, one of my favorites. And then hypertonic fluid, which we will discuss as a part of osmotherapy. So the goal of osmotherapy is to teleologically draw as much fluid from the brain to reduce the edema. Historically, mannitol has been the main go-to drug. But over the last few years, we've noted that mannitol has some negative effects that we just we had not really considered in the earlier days. With a broken down blood-brain barrier, it can actually cross over into the brain and cause worsening edema. It causes a very severe osmotic diuresis. So you're trying to volume expand a patient, and then they start peeing their brains out, almost literally, that it's self-defeating. So usually we say, now we say mannitol the first 24 hours, and especially if you don't have an ICP monitor, the patient comes to the emergency department, has clear signs of papilledema, you don't really know what to do, you just kind of slam some mannitol into them, and then you start making all your phone calls to everybody else, and to bring your team in, to get your ICPs down as much as possible. Hypertonic saline is probably going to eclipse mannitol relatively soon. There's multiple studies, unfortunately relatively small studies, that show that it's at least equivalent to mannitol, and there's 1 or 2 studies that show that it's actually superior to mannitol. But it's very difficult to get large volume studies so that we can actually test this. So it's unlikely that we're going to get a randomized, double-blinded, large-scale, multinational group together to study it. But what we found with hypertonic saline is that it actually has some anti-white cell factors where it decreases white cell activity within the CNS. It can augment the cardiac output. You don't get an osmotic diuresis with this. And it generally reduces the viscosity of the blood and just generally improves things. So I think hypertonic saline will likely be the future. A lot of the studies actually, interestingly, came from EMS and wartime studies, where it's very easy to carry a very small 10 ml vial of 20% saline versus a liter of normal saline. So they just started packing all the soldiers with 10 to 20 vials of 20% saline, and when someone gets injured, they think that they have high ICPs, they give a dose, put them in their little gurney, little flotation thing that they use, and run them back to the military hospital. So it definitely, in trauma, has a place, and I think we have increasing evidence for its use in subarachnoid hemorrhage or anytime we have a patient with high intracranial pressure. And I don't have stock in the company, so don't need to worry about that. So medical management, cardiac monitoring, seizure prophylaxis. I think every surgeon, neurosurgeon, and interventionalist has an opinion about, different opinion about seizure prophylaxis. My general theory is if they look like they might be having seizures, I give it. But there are side effects to any medication that you give. So giving it to every patient, if it's not going to give them a benefit or not going to give them a better outcome, can potentially be dodgy. So it's really dependent on the site where you're working, whether or not we're going to give seizure prophylaxis. We'll discuss electrolyte abnormalities. Linda has very graciously given you a nice chart discussing diabetes insipidus, syndrome of inappropriate ADH, and cerebral salt wasting. You'll see a spectrum of all three. Cerebral salt wasting is much more rare than what we truly think it is, but you will see some patients who present who have FIADH and DI, or what looks like components of both, and just careful electrolyte monitoring, looking at serum osmolality, looking at urine sodium, and constantly following patients when you start noticing changes in their urine output is best. But if you have a low sodium and you have a low to normal urine output, it's probably FIADH. If you have a dehydrated patient with a low sodium, it's likely cerebral salt wasting. If you have a dehydrated patient who's been peeing 600 mils per hour for the last 3 days, you likely have DI. But you can also get other electrolyte abnormalities, potassium, calcium, and then hypoosmolar state. DVT prophylaxis is probably one of the more neglected interventions that we have in intensive care medicine for these patients, because everyone is not sure. They're bleeding in their brain. Should I give them heparin? They bled 3 weeks ago. Should I give them heparin? And we go back and forth. But again, it depends on your site. Previous hospitals where I've worked in, at 14 days, absolutely they must have some DVT prophylaxis, whether it be heparin or Lovenox. But some sites will start at 7 days. But again, that's a discussion between the intensive care, the proceduralist, and neurosurgery. GI prophylaxis, because these patients do have high risk for GI bleeds. Nutrition, I love my nutrition. I like to eat, and I couldn't pay attention to myself when the curtain went up. So nutrition must be addressed in all patients. Glycemic control. Again, sometimes your stroke or your seizure is not a seizure. It's actually hypoglycemia. Or your patients develop such severe hyperglycemia that they're in a diabetic coma. So glycemic control is very important to outcomes in these patients. And then early involvement of physical therapy, occupational therapy, and speech, and swallow therapy. As I said, I'm very food focused, so most of the patients will have a swallow eval and on nutrition within minutes of arriving to the unit. And then patient and family communication. I think this is one of the major issues that we have problems with in the ICU. We have these patients, we don't actually know what direction they're going to go in, and for some of us, we think silence is better and not telling the families. But if we're thinking something, the families should be in on it, because they are a part of the team. They are there at the bedside on a day-to-day basis. So keeping it clear to the family, I noticed that there's vasospasm, I'm quite concerned. I'm going to give the neurointerventionalist a call. Neurointerventionalist comes, says I think they should go down for a procedure, and this is discussed with the family. But keeping those pathways open, and there will be a patient who, 85 years old, completely obtunded with a GCS of 2T, and they're intubated, and we're running around like chickens with our heads cut off and trying to do all these aggressive interventions. The family's sitting there saying, I don't really think she would want this. And again, keeping that open communication so that we can say, no, we can't give her a good quality of life. We should start talking about what our goals are and defining those goals of therapy at any point in the hospital stay, I think is important. Okay, so in summary, ischemic CVA, you have to lump them all together, reduce the blood pressure, progressively avoid extremes of blood pressure in the first 24 hours, subarachnoid hemorrhage, definitive therapy, and then post-therapy, hypertension, hemodilution, hypervolemia, and control of those secondary complications from hospitalization. Any questions? The cookies are good. That could be a question. No questions? This is a picture I took this time last year in my previous home in Western Australia, and I look at it every once in a while and I think, damn. But the snow is beautiful. So beautiful. Anyway, no other questions?
Yeah, that next picture was animal.
Oh, so being from Chicago, I'm afraid of anything smaller than a child. So this is a quokka, it's only found on one island in the whole world. And they would come into our house and terrorize me. And my children would try to play with them. I'd say, children, don't touch them, they have rabies. So there's no rabies in Australia, but they're dirty. But they are so cute. They're like little teddy bears that will steal your food. And they're like, Well, they look actually kind of like large rats that hop. So, and this one is actually a wallaby. This one's a quokka. This is a wallaby. And the wallabies are not afraid of, well, they weren't afraid of me. So I would, and they're just, in one area where I worked, they were all over the place. So I would take the train to work, and on the sidewalk there was a homeless man, and I was just kind of like, homeless man. But then a wallaby came. I was like, a wallaby! So I called a taxi. Not the homeless man, the wallaby. Anyway. No other questions? All right, good.